Welcome to How I Doctor, where we're bringing joy back to medicine. Today's episode is a little bit different. In the spirit of Thanksgiving, we're taking a moment to slow down, breathe, and acknowledge all of you in healthcare who are showing up today. Whether you're on shift, post-call, grabbing turkey in the break room, or finally collapsing on your couch after a night in the ED, the holidays look different when you're a clinician. And whether this one feels joyful, exhausting, or somewhere in between, I'm grateful that you're here. And while we're at it, thank you for listening. Truly. When we started this show, I thought it'd be a fun side project. Maybe a handful of friends and colleagues would tune in out of pity. Instead, so many of you have reached out, subscribed, signed up at offcall.com, and shared how these conversations have helped you feel a little less alone in this wild job we all do. I can't tell you how much this means to me. I'm genuinely humbled and, if honest, a little shocked that so many physicians want to spend part of their day hearing me blather on. I'm thankful for every one of you who's joined this community, whether this is your first episode or your 50th. A special shout out to Dr. Scott McCusker, who, let's be honest, is probably already halfway through this episode before most people have even found the link. And while we're handing out thank you notes, I have to give it up to two companies that believed in this show early and helped us grow, Abridge and Evidently. Both are building thoughtful tools that support clinicians instead of getting in our way, and we're grateful for their support of the work we're trying to do here. So today, as we celebrate Thanksgiving, we're sharing a best of episode, the moments, stories, and insights from past guests that continue to get stuck in my head. Let's dive in. The reason I am kind of bullish on AI and kind of desperate for AI to help is I just see our patients getting sicker and more complex every single day. I don't see us going up on residency slots. I think, telemedicine made us more virtual and more flexible, but maybe our physical exam skills have gotten worse or more fragmented. Like you do a telephone visit and you email your doctor and then you maybe still see them in person. I want to help shape AI because I don't know what other choice we have. At some point I'm going to get sick with some disease that's going to need someone to be focused and paying attention and caring. And so, that's why I am happy to have people like you that are trying to tell this story, because I think we're going to have it. I don't see a future where we have still good medical care with the same number of humans, or honestly fewer humans. There are lots of doctors are leaving medicine, nurses, all the professions. I think people are not loving it as much as they used to.
The stats that are just programmed inside of me, whether or not they've shifted a little bit over the last few years or not, and that I feel like I recite like a robot everywhere I go, is that 2 out of 5 doctors don't want to be doctors in the next 2 to 3 years, and 30% of nurses or 27% of nurses don't want to be nurses in the next 12 months. And I think technology has already helped a lot over these last few years, and we've seen some studies suggest that burnout is coming down thanks in part to this technology, but there's so much work to do. And I think you're right. We are at a really interesting historic moment.
It feels like a transition,
right?
That we're
right.
It feels like the humans still have all the responsibility, and that feels like that's getting bigger and deeper and heavier, and that's that's driving people away. And it's also just getting harder. People are on more meds, which then makes them have more side effects, which then complicates everything. But it does feel like we're in the transition period where we could, in 5 years or 10 years, we could have we have the technology now that we can envision a totally different way that healthcare works and actually works better, I think.
100%. I think that has to be the goal. I think we've stretched the rubber band, the clinician rubber band so far.
It's like getting those little micro tears in the thing.
Exactly. But even then, even when you sort of go up and you start to think about the system on the provider side, on the health system side, on the payer side, everybody's an extremist right now. Nobody is actually doing well. And as much as we want to sort of make it about this entity versus that entity, actually everybody is struggling at this moment in time. I feel like those are the moments where you can figure out new models. I used to be a corporate VC for a health system, and we would invest in companies. And if a company came in one year and they had a handful of big AMC logos or something like that, it would be champagne and wine and party and celebration, because it's so hard to get distribution, especially when you think about the health system end of the segment. of healthcare. And this moment has been insane. I don't know if you saw that, like, was it Menlo who published a report in the last few weeks that suggests that healthcare is actually adopting AI faster than any other industry, and like against all other industries, like it's like something like 2.4x.
And I think like the health system's even more than the payers, which I know thought, no way. Like to me, I mean, I've never worked for a payer, but like if I was a payer, I'd be like, oh, I have this mountain of data. There's so much I can do with it. And I love my health systems, but I don't think of them necessarily as the fastest change agents. Healthcare has never been the fastest agent to adopt anything.
Yeah.
You know?
It like happens in spots though.
Yeah.
You know, like with my bias as a cardiologist, you go into the cath lab and you've got access to crazy stuff. Yeah. And then you leave the cath lab, and then, you know, the farther away you go, you're getting exposed to lower and lower fidelity tools. Yeah. And so like healthcare is so interesting, but it feels as if we're figuring out where the actual opportunities are, and we're figuring out where the actual value is getting created. And in some ways, I think we're starting there. And I think our category in Abridge is interesting in that it's lower stakes, but it's still at the heart of care delivery. Yeah. It's still in this sacrosanct moment where people are most vulnerable. And so there's so much opportunity to create impact, you know, obviously with the right mission and the right North Star. But in general, it's like those lower stakes flows. But I think over these next couple of years, what will be wild is we're undoubtedly going to see like technologies and companies start to really push the envelope on use cases like clinical decision support. I'm curious what you're seeing, where you think this next year, where we're going to like push the envelope the most.
Interviewing on my own podcast. I think there's a great like first generation of AI, especially like generative AI.
Yeah.
And then I think there's going to be a second, like, you know, there's some people talking about some AI bubble that's coming. Yeah. I think what I'm seeing is there's going to be a second wave of, especially like for healthcare, like AI plus some guardrails and some supporting functions and tools that like help make the skyscraper be a little bit more stable, and will alleviate the health system's like anxieties or worries around error, accuracy, bias, things like that. So that then they're like, oh, you've actually you've like de-risked this problem. Oh, like it's actually easier for us to get on board with your concept now.
Yeah, I agree.
Danielle, I literally have your New York Times op-ed on speed dial. I have it like as a link in my bookmarks that makes it really easy for me to pull up and send to other people. If you haven't read it, it's called The Business of Healthcare Depends on Exploiting Doctors and Nurses. I love the title, but I love the text even more. Danielle, you wrote that before COVID, which I think is also really telling. I think so much of medicine today, we maybe want to blame on COVID, but I think many of these challenges started, you know, at least a decade ago, if not longer.
You write lots of stuff and put stuff out there, but that's the one article that people keep coming back to. And I think because, and inadvertently, I would say, I ended up tapping into what I think is an essential issue of what's wrong and maybe also what's right with medicine today. You know, we all love what we do and we love who we work with. And one of the reasons we love who we work with is that we share this ethic. You know, every time I pass by my hospital, I actually live nearby, so I sometimes pass it at night, and I realize that the chain has never been broken. When I signed out my last day of residency in the MICU, I signed out to someone else who signed to someone else, and that chain has never been broken.
Yeah, I love that.
And I know that all the time because we never let that ball drop. Every nurse shift that ends is signed out to the next nurse, and that has not stopped in all my years and decades of medicine, all the years we've all been practicing. It's just an amazing miracle of what we do, which is why I feel like medicine and nursing is less of a job than an identity of who we are. But then I look at how the institution of healthcare as an industry is working, and it relies on that. And I initially didn't want to say exploits.
Yeah, did you get to pick that that headline? I know often the editors choose for you.
The editors, the headlines are all the business of the newspaper or the journal. But I think that it it became apparent that that is the mortar that holds up the house that is healthcare. And if we all clocked out at the end of our hours, the end of our shift, the end of whatever our to-do list is, it would crumble in a second. It wouldn't last more than a minute because, today's Friday, I don't see patients today, but of course I'm logged into Epic and I missed a patient yesterday who has dementia. So we called and did a televisit today. I have a patient who's seeing a PA. I know that the potassium is low and they need to change their blood pressure medications. And I made sure that got through because I can't go off to my weekend until that's done. It doesn't work that way. And so as the business of healthcare expands, and basically this is looking to make money, at least in this country, you can keep expanding. And one of the things that turns out to be absolutely elastic is the professionalism of doctors and nurses. And if they didn't have that, none of this could happen.
It does feel like that oath that I took. It wasn't technically the Hippocratic Oath. It was a modified one and we took at Stanford. But that oath certainly feels like it is abused and relied upon. And in fact, I've had doctors on this podcast tell me they know administrators who've said, well, you know what, the doctors will do it because it's in the name of patient care. So we'll just use that. The administrator is getting a business outcome that they want, essentially free labor or cheaper labor. But the doctor is going to do it because it's the right thing to do.
We have 20-minute patient visits because our patients are very complex. Most don't speak English, a lot of psychosocial issues. Even then, most visits take well longer than that. But for new patients, we were given 40 minutes. But the backlog of new patients who were waiting for medical care was so enormous. And the solution became to cut those new patient sessions into 20 minutes so you could see double the number. Now, of course, there isn't any extra time given or extras. It's just twice as much work. And of course, every one of those patients generates a ton of work, labs, new diagnoses. Some of these patients, I had a new patient who was 2 weeks post-discharge after a month intubated in the CCU with new onset, heart failure, who spoke only Haitian Creole. And I thought, okay, 20 minutes? I can't even read the consults, read the discharge summary in 20 minutes. And so the only way that works is because we will not leave without reviewing the labs or finishing the time. I had another new patient who spoke only Venezuelan ASL, sign language. I had to have a Venezuelan and an American sign interpreter plus me. So a 3-way chain. And of course, it took an hour. And you just can't, and of course, I can't stop. I can't skip the allergies or the past surgical history. You can't just, not do those things. So yes, and where does the time come from? It's our free time, which of course we understand and accept. We're not shift workers in that sense. Nevertheless, there's a point where it becomes exploitation. We realize, well, we can just add more work and that'll get more efficiency or more profit because we know the nurses and doctors won't leave until their work is done.
I struggle with this a lot. Is there a line? Is that line dynamic? I do truly feel that this is a profession. This is a calling. I think people younger than me are maybe more likely to think of it as a job. But where is that line where it becomes maybe exploitative versus just part of being a calling?
It's very hard to draw an absolute line, but I think when we distinguish between the emergencies and the routine, when we do this routinely, if it's all a state of emergency is a routine thing, then we've become exploitative. But also, and when I think in terms of when is it beginning to harm patients? Now, of course, we'd love to say when it harms clinicians, but I don't think that the higher-ups really care, honestly, other than lip service. But harm to patients, medical errors, lawsuits, those do actually count, thank goodness. But we can point out when we feel that, for example, when I've cut corners with a new patient, I have one of my new patients, I realized that I didn't confirm which diuretic he was on and which dose. And, it tormented me. I kind of had to keep calling and tracking down for days till I got him and pinned him down. Is it LASIK or Bumix? And how much? Or not at all. Right. Because I can't leave that stone unturned, that it feels wrong. And that happens not infrequently. I also had a time when I had 2 new patients, Spanish-speaking middle-aged women, who both walked in with A1Cs over 9, that is, newly diagnosed diabetes, and one had a TSH of 300 of hypothyroidism. And these just sort of floated in, and I mixed them up. I called one back twice because I got just confused and thought that this is dangerous. And so when we start having patient harm, I think we're, of course, ethically obliged to speak up. This is harming our patients because that goes right against our oath. I wish the idea of our own well-being mattered, but I know that it doesn't really.
Hey, today's episode is brought to you by Abridge. We all feel the weight of clinical documentation that follows us home and chips away at our personal time. With Abridge, clinicians can change that. Abridge drafts a structured, clinically useful note at the point of conversation, all seamlessly integrated into Epic and customizable to your specialty while you review and finalize every word. Clinicians have reported significantly less after-hours charting, improved satisfaction, and dramatically lower burnout. Let technology support your day instead of interrupting it. Visit abridge.com to learn how you can focus more on patient care and less on paperwork. Let's put the care back in clinical care. A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights. Chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today.
Part two, then, is how do you simplify the whole economic process? If you look at how insurance plans are designed and the responsibilities associated with those plans, it's criminal. It should be criminal. It is the antithesis of trying to optimize for patient care. And so if you look, let's just say you own an insurance company and you're creating a variety of plans that you want to sell. Well, it's up to you as the insurance company to determine the premiums you're going to charge, the features you're going to offer, and the patient responsibility, the deductible, the out-of-pocket, the co-insurance, whatever it may be. Well, guess what? You go then to CMS, and if it's a Medicare Advantage plan or an ACA plan, you try to get it approved, and typically they'll approve it, with some constraints. And then you'll offer some for self-insured employers, because more than 50% of people get their insurance through an employer. Well, then the goal from the self-insured employer is to try to make their employees and their families happy, right? They're going to make determinations of which plans to offer. And then each of us, whether you're a doctor, whether you're a nurse, whether you're a janitor, whether you're an accountant, you're going to choose the plan that's appropriate, you think, for your family. You know who's not involved in any of that?
The patient?
No, you.
Oh, the doctor, yeah.
The doctor in the hospital, right?
Yeah.
The care, right? But who takes the patient financial responsibility risk?
Me.
You
yeah.
do. Yeah. So if you're an independent physician that's seeing patients in your office and you happen to be in Humana or whoever, United, you pick one of any of the Buca's networks. All right. Well, if they design a plan that you had nothing to do with the design and one of those patients walks in the door, you don't get to look at the financial statement, fortunately, of the patient. But if they design a high deductible plan and they made it available to somebody with a take-home pay of $25,000 and there's a deductible of $5,000,
they're hosed, yeah.
you're screwed.
Yeah, I guess that's the interesting
Now,
thing.
the patient,
I'm saying the patient's screwed. The hospital.
No,
the
the
hospital and
patient's
the
not
doctor.
screwed because the patient's getting care, right? Your contract with that network says even if they're broke as a joke and don't have two nickels to rub together, you have to still care for them.
Well, and especially as an ER doctor, we have this
Well,
rule called
that's
EMTALA
law, right?
that we have to take care of anybody and stabilize them regardless of ability to pay. Yeah.
Well, put that aside because of EMTALA,
Sure.
right? Put that aside as a unique situation. If you're seeing patients for whatever your specialty is, primary care, and you're in your office or you're at the hospital where you keep an office, and they walk in the door and they have a boo-boo, and that boo-boo is going to cost more than a couple $1,000s, and they have $17 in the bank, well, whatever the delta is, you're responsible for figuring it out. But wait, there's more. It gets worse because that financial responsibility for that risk of debt default that you take on, now you're also responsible for figuring out a payment methodology if there is one. And if that patient now all of a sudden is accumulating $5,000 in debt, then 10,000, then 20 and goes bankrupt, who gets blamed?
Yeah, me, because I charge too much.
Not even, yeah, and it's not even your fault, right?
Yeah,
It's
yeah.
just the plan was designed in a
To
manner
fail. Yeah.
so that you knew that there were gonna be buyers of this plan who can't afford the deductible.
And the insurance companies surely love it because they have no risk because the deductible's huge.
Right. It's more profitable for them, right? And so from a PR perspective, now all of a sudden, oh, medical bankruptcy, there's X hundred billions of dollars in medical debt. We got to get rid of it. There's X percentage of people and number of people who are declaring bankruptcy, which is for medical costs, which is horrible. But it all goes back to the simple side of it, the plan design, right?
Mark, you're hitting at something that I was going to bring up later. There is a sense among physicians that we are the face of healthcare. We're the bosses, we're in
Of
charge.
course.
And so we are now, I think the big feeling that physicians are having right now is that we are also to blame. And so you're bringing up a really interesting side of it that, like, the feeling from the patients is that we're charging too much, even though we're taking on the risk. And the patients also similarly feel like, well, the doctor should be deciding if I need this CT scan or if I need to get this medicine. But so much of it now is controlled by the payers as well. Like the payer will refuse to allow the CT without the prior auth too. Yeah, yeah,
Oh
yeah,
yeah, put
yeah.
aside pre-auth. We'll get to pre-auth. Look, let me just tell you up front, doctors are underpaid. Like when I look at bills, of individual bills, and it might just to pick one out of thin air,
Yeah.
heart transplant, right? $25,000. Amount paid to the doctor,
Yeah,
$2,200.
for literally taking a heart out.
Yeah.
Yeah.
If I'm getting a heart transplant, I want that motherfucker doctor to make $10,000 so he's paying attention or she's paying attention
Yeah.
and not worried about getting to the next heart transplant or worried about the patient that's got a boo-boo, and so it's such a fucking mess, right?
The second piece that you raise around emergency medicine is fascinating to me because I've had an opportunity to study emergency medicine trainees. So, what happened to me is after being a medical education researcher and a medical educator, I started to ask these questions after I reviewed the paper, thinking, well, if this is happening for faculty, what's happening at the training level? Because at the end of the day, most of the way in which salary is advanced, is through initial offer, maybe a retention offer, but there's also a lot of merit pay, right? I started thinking a lot about merit because merit is based on evaluations. And that is actually the currency of how we advance trainees is their evaluations. So emergency medicine was fascinating because we had access to this database of real-time evaluations in emergency medicine for multiple sites. And that was important too to kind of make sure that we weren't just calling one place out, but if it's a systematic issue, it should be everywhere. So we had 33,000 evaluations of real time that were milestone based evaluations, sort of looking at how people advance. And we saw that at the beginning of residency, in a field where it's like pretty even, there was no difference between how female residents and male residents were being evaluated. But by the end of residency, there was a 3-month, what we call promotion gap, where the women were lagging behind 3 months and sort of meeting their milestones. 3 months, that's like a quarter of a year, right? That is significant. And so it was like hard to explain why is this across so much data occurring,
Yeah.
It's a pretty big finding. We published that and then we went one step further to look at the narrative.
I was just going to ask. Yeah.
And so what was the story? Well, it turned out that when you look at the narratives, because people give their circle their
1 through 5, and then they'll write a couple lines about, yeah.
these seasoned sociologists at U Chicago who looked at all the narratives and kind of impartially like put it all together. And it turned out that when a male physician was struggling he would get coaching level feedback, that would provide the opportunity to improve. And you would see the improvement occur.
Yeah.
But a female resident struggled, particularly with leadership tasks, not in the first year, because the first year you're kind of following orders, as you
Yep.
know, Graham. But in the second year of residency, when you're kind of team leader, code leader, running a trauma, the female residents would often get discordant feedback, and they would be told either they need to be more confident. So Emma needs to be more confident in her resuscitations. And the next month, Emma fictitiously is being evaluated by somebody else. Doesn't matter if it's male or female. Same discordant feedback.
I was just going to ask, yeah.
Then Emma is told that she's argumentative. She argues too much with the attending and needs to be more passive.
Agreeable. Yeah, more, yeah.
Yeah, more of a team player, okay?
Oh, yeah.
And then the next month, right? Then Emma is now getting punished again because she's like tried to,
recalibrate a third time.
Not gotten it yet. And so this was very interesting to our sociologists because this is also very common in many other industries where women are having to take roles that are primarily, when you ask the public, that is mostly thought of as male dominated, then women are often punished for stepping into those roles because they are going against the gender norm.
Sure.
And so that was very fascinating to us to see that qualitative story play out as to why this was happening, not in the beginning of residency, but in the end of residency when you're really needed to be a leader.
I argue that emergency medicine, the way that it's being practiced today, is not a sustainable career anymore. The standard W-2 model is not sustainable. Our specialty specifically, but even medicine in general, but being specific about emergency medicine, has such a high burnout rate that it's almost not a question of if it's going to happen, it's a question about when. So I argue that as a W-2 employee, you have no control, and you have very little control over your schedule, how when you work and when you don't. And the number one reason why doctors actually burn out is because they have that feeling of lack of autonomy and control. Locums flips that on its head. Now, what I do now as a locum is I schedule my life events first on my calendar for the next few months, and then I fit in my work blocks when I want to. Instead of, as a W-2 employee, you're just handed your schedule, and you have to try and fit in life events and obviously miss a lot of things as well as a result. So that's my argument. And, for me, I'm living a very fulfilling life outside of medicine, which makes me very fulfilled inside of medicine.
Ollie, that's a great answer. My first question was literally, if you had to sell a skeptical colleague on locums, what would you say? But I think you literally answered it right there.
I was talking to a pediatric emergency physician the other day, and she was interested in a job. And I just showed her my schedule. She's like, I had some family problems at home. There's someone she had to take care of. And she just felt like guilty for not being home enough. And I literally showed her my schedule over the last few months. And she saw these massive chunks of time off, 3, 4, 5 weeks at a time off. And her jaw just dropped. She's like, is this for real? Like, are you like just playing me for a fool? I'm like, no, this is my reality. This is my new normal.
Well, Ollie, I think it's fascinating. Is this really an argument that you are making specifically for emergency physicians? Or do you think this is a wider argument for shift workers, or is it for all physicians, or like how broadly do you view that kind of vision?
Yeah, so being an emergency physician myself, I can absolutely speak to emergency physicians without any hesitation or doubt. But I know several other specialties that are thriving in locums as well. GI does very well with locums. Anesthesia is super hot. Radiology is insanely hot right now. CRNAs, which aren't physicians, but they're very hot as well. I have a friend who's a medical oncologist doing almost 7 figures doing locums, right? Making more than double than what he would make as an employee. So just about any specialty you think about, like there's opportunities for locums that can free you from the medical matrix, as I call it.
That's fascinating to hear. I think the two that surprised me the most are GI and oncology, because I guess I view those specialties as needing some level of consistency in care, and those specialists are building relationships over time. Am I wrong there?
No, the reality is there's just not enough docs to go around.
Yeah.
I mean, there's just such a massive shortage. So these doctors are leveraging their skills, especially for GI. It's a more procedural based specialty.
Yeah, sure.
And
Yeah.
so, there's definitely a demand for that. Every hospital I go to is short of GI docs.
Of somebody. Yeah.
They don't have an ERCP doc, and they're just transferring patients out and all this. This happens quite commonly at a lot of the sites that I work at that are, a couple hours outside the big cities.
Ollie, how did you get started in this? You mentioned you started out, I guess, right after residency as a W-2, as an employee of somebody else, right?
Yes. So when I graduated in 2014, I just went with what everybody else was doing, taking a W-2 job. And I was quite happy with my actual job itself, but it was just the fact that I had no control. And it was a light bulb moment that I had when one of my friends said about a year in, "Hey, Ali, I thought you were going to have more time off to do more things than you do right now, because it sounds like you're still pretty busy."
Yeah, I mean, that's kind of the pitch from emergency medicine is like, when you're on, you're on, when you're off, you're off, right?
Yeah, which is nice, but like your schedule throughout the week, it fluctuates, and especially as a new grad, when you're not like a senior who's controlling the schedule, making the schedule, you kind of get the short end of the schedule. So nights into late night shifts, or what do you call them, the swing shifts, morning shifts, just everything just kind of all jumbled all over the place, and I was getting burnt out. I'm like, man, you're right. This is kind of like not as good as I thought it was going to be. And then, I just started picking up some locum shifts on the side just because I wanted to pay off my house that I just bought. I was doing and some loans that I had accrued, obviously, during med school. So I was like, let me just make some more cash on the side. Not intending for this to be anything. I was just like, hey, I'm just going to work on the side. And then after like 4 or 5 months of doing this, I realized that a week worth of locum shifts, I was making more than an entire month of my full-time job as an employee.
Wow.
That was my second light bulb moment. I'm like, wait a minute, right? Like the math isn't mathing here. So now I have a choice to make. Am I going to devalue myself by working twice as hard to make the same amount? Or I can either make double or work half as much and make the same amount. Does that make sense?
Yeah, totally.
And so I had to it was a hard decision because I actually liked a lot the people I was working with. And again, this very supportive department, I actually really liked it. And that was a very hard decision for me. But ultimately, I realized that I had to do what was best for me and my family. And I decided to kind of make that switch over to locums.
Ollie, I think locums can feel kind of risky to some. One of the many benefits, I would say, of employed W-2 work is you're kind of guaranteed shifts. The job probably comes with benefits. Maybe it's got a 401k and it probably has health insurance, hopefully. What do you say when someone says, I like the stability of my W-2 job where I've worked there for 10 years, and maybe they do have a great practice environment like you did as well?
Absolutely. I get this question all the time, and I'm laughing just because it's such a common myth. I argue that locum tenens is actually more stable than W-2 employment. Now, it may not be 100% the case across the board. Like, for example, a place like Kaiser, where they have established hospitals and systems, you're employed there, and you're not. No one else is taking over that contract, right? But I'll tell you, about a month ago, I spoke to another physician, and on the East Coast, she is an academic physician, emergency medicine. She worked for this hospital system that was teaching residents called MCP Hahnemann in Philly.
Yeah, I've heard of that. Yeah.
She was there for many years, and then they just shut down the hospital. There was, I don't want to go into details about that, but then she transitioned over to Crozier, was an academic physician there, worked there for several years, and then they shut down. So that's one example. And then another example of the hospital system that's just about an hour and a half down here in Delaware. Independent group that's been there for 30 years. Hospital decides a year and a half ago that we're taking you guys in as employees. Take it or leave it, right? I can't tell you how many numerous times I've heard from directly in my DMs, dozens, if not hundreds of times, just things that I'm seeing over the last 10 years myself. So you have no control when you're an employee at all. Any contract management group can come in, the hospital can choose to employ you anytime, and then you're just stuck having to either take a contract that maybe is not what you initially signed up for, or you have to figure out what are we going to do next. When you're already established there, your kids are going to school, your family maybe is there, you have extended family there, and you haven't played the locum game yet and don't know how to play that, now you're a sitting duck, right? Whereas with locums, I can live anywhere I want on this earth.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.